Good afternoon. I'm very happy to welcome you to today's webinar, New Approaches to Cardiovascular Aging, Central Pressure Waveforms and Arterial Stiffness Assessment. My name is Doug Krasinski. I'm with ATCOR, and I'm honored to be joined by Dr. Mark Houston, who is the director of the Hypertension Institute at St. Thomas Hospital in Nashville, and certainly someone who's very well known to this group. So Dr. Houston, thank you very much for being with us today.
Thank you, Doug. It's a pleasure to be with you.
Thanks. You know, these times of global health crisis, some of the normal greetings are kind of out the window, but I hope things are relatively well there.
They are. Thank you very much.
Okay, all right, that's good. What I'd like to do in terms of agenda is I will present a series of slides that provide some of the clinical and technical background on these topics, and as efficiently as possible, I'll get to the real meat of our discussion, which is interchange with Dr. Houston to get his perspectives and his expertise on these matters. So with that, I'm actually going to shut down my camera and I'm going to display only my slides to go through this series of slides with the group. As we know, we spent, for the last 100+ years, brachial blood pressure has been measured using a brachial cuff. And there's lots of good reasons for that. First of all, of course, it's convenient to do and can be done in just about everyone. And also because brachial pressure tracks risk in populations. And of course, that's the reason why it became of interest to insurance companies. But as we have evolved medical care and moved more and more towards personalized therapeutics and treatment, it's always better to have more patient-specific information where possible. And as I hope you'll see today, the availability of central pressures and central pressure waveform do provide that individualization and differentiation. We all know that there have been a number of hypertension guidelines that have been released in recent years, and regardless of which you might favor, there's a number of things that are very well known. First is that hypertension is highly prevalent in the US and around the world. It is not controlled well at all. Many people who have hypertension actually are not aware that they have the condition, even in the developed world. And lastly, some of the cases of lack of control relate to a patient's intolerance of side effects of drugs. And so if you can imagine an ability to be more precise in drug selection and possibly avoid a drug that might not have been effective, and avoiding those side effects, there's a hope there that in and of itself will improve compliance with the treatment and therefore add a little bit to the control rates. A brief discussion of terminology. The terms central blood pressure, aortic blood pressure, and central aortic blood pressure are used interchangeably here and throughout the literature, but they all refer to the pressure that we measure in the ascending aorta. Obviously, the pressure at the ascending aorta is not the pressure in the brachial artery. It's also true that the pressure that's experienced by the kidneys and the brain and the heart itself is in fact that aortic pressure. So to the degree to which there's a difference between the brachial and central pressure that might not be otherwise captured, it becomes important to find ways to actually measure that central pressure. That's what we'll talk about today. Very briefly, on the panel on the right here, you can see the output of the SpimoCor Excel, which has lots of numbers, which we'll talk about, but certainly is data rich. And when you think about blood pressure management today, setting aside the things that we do know about patients, such as their history, their comorbidities, but beyond that, when we measure blood pressure, we just have two numbers. If we can add to that this extra information that we'll discuss today, it's very much like adding an electrocardiogram to knowing only someone's heart rate. A little bit about physiology. As the heart contracts, pressure energy travels out through the arterial system. As that pressure energy meets places such as bifurcations and vascular beds and other sources of impedance mismatch, a little bit of that pressure energy gets reflected back towards the heart from each of those locations. They actually will sum then to a single reflected wave for each cardiac cycle. You can see an example of that here in a relatively simple illustration. Here we have the the incident pressure wave, if you will, and then we have the reflected blood pressure wave. The waveform that's measured, which is the harder line across the top, is the simple summation of the outgoing incident pressure wave and the reflected pressure wave. But as we age and with disease, the arterial system will stiffen, and the speed of that wave reflection will actually increase. So again, while these are relatively simplistic diagrams, I think they're very they're very instructional, if you will. On the left, we have the example I showed, which would be someone who's got very late wave reflection. In fact, the peak of the reflected wave is actually during this diastolic period. While on the right, what we've done is we've simply moved that reflected wave earlier in time. In other words, returning faster to the heart. And by that simple shift of the reflected wave, going back to the fact that we add the incident and the reflected wave together, we have what we call an augmentation of the central systolic pressure. So we've actually increased the systolic pressure from perhaps 112 millimeters of mercury to about 122. Now, the first two terms I would like to define here are augmentation pressure, which I've just mentioned, which is basically the difference between that peak and the inflection point in the waveform. I won't go into the deeper detail for now, but the difference in that peak and that inflection point in this case is about 10 millimeters. And then we have a parameter called augmentation index, which is the ratio of that augmentation pressure to the central pulse pressure. And of course, here we have a central pulse pressure of about 42 millimeters of mercury, 122 minus 80, and an augmentation pressure of about 10. So we have an augmentation index of 10 divided by 10 divided by 42, or a little less than 25%. But what does a change in wave reflection mean in terms of potential CV risk? Well, there are three parameters that we can look at very quickly from looking at the overlap of those two waveforms. First of all, as I mentioned, we've increased the pulse pressure by about 10 millimeters of mercury. And so that's an increase that is directly impacting potential stroke risk, a risk of kidney damage, because of the fact that those organs directly experience that central pressure. Secondly, we've increased the area under the curve during the systolic period, which is to say this sort of hatched area with these upward arrows, which is the area that's been added from that wave reflection. So keeping in mind that it's a reflection, so a resistive force, this is a resistance that the heart has to pump against. So we have a muscle working against resistance, which of course drives risk of LV hypertrophy. And finally, we have a reduction in coronary perfusion pressure. And of course, the coronaries are perfused during diastole. And since we've moved the reflected wave earlier in time, we have reduced the diastolic pressure across the diastolic period, which of course can drive ischemia risk. Now, here we have a slide that plots many patients' central systolic pressure on the y-axis against their brachial systolic pressure on the x-axis. There's a few things that you'll notice immediately. One is a very high linear correlation between the two, but that should be expected because these are paired measures of blood pressure within an individual. The second thing that you notice is that central pressure is always less than brachial pressure because the pressure amplifies as it moves away from the heart. But the third thing that you notice is that there's a very wide range if you look at any specific brachial systolic pressure. If you imagine a vertical line straight up from the 150 here, or 150 millimeter brachial systolic pressure, you can actually see that in this population, there's about a 40 millimeter range of measured central systolic pressures for one specific value for brachial systolic pressure. And here we start to understand that that variability of central pressure, given that that's the pressure the target organs are experiencing, can start to add dramatically to the information we have from just understanding something like a brachial pressure. Now here I want to show you, just bringing this down to just two patients. In the left panel that you can see now, we have a red waveform and a blue waveform. And these are two different patients, but they actually happen to have the same peripheral pressure or brachial pressure, 144/90. But the next thing that you notice is that the red waveform is quite different from the blue. It's wider, And that's actually an indication, that shoulder is actually an indication of wave reflection. So here you would expect, and you will see, that in the central pressure, the red waveform will have a higher central pressure with an increased augmentation or augmentation index. And that's exactly what we see. So here we have an example. Imagine two patients in adjacent rooms. Both have had their brachial pressure measured and both are 144/90. Many of the treatment decisions might be similar with only that information. But having a central pressure and seeing that there's a 14 mm difference between those in that pressure the target organs are experiencing certainly may modify the way these patients are treated and the way their risk is understood. So with spinal cord technology, there have actually been probably now over 1,500 peer-reviewed published articles. I promise I won't go through all of them, but I will go through just a few, because what they do is they sort of build on each other and show you how the evidence is accumulated and how the utility has shown through with these measures. The first one is the CAFE study, and CAFE stands for Conduit Artery Function Evaluation. CAFE was a sub-study of the ATCOR trial. ATCOR stands for Anglo-Scandinavian Cardiovascular Outcomes Trial, and this is a very classical antihypertensive study design. It compared amlodipine, a vasoactive calcium channel blocker, with or without ACEs, against atenolol, with or without diuretics, in managing hypertensive patients. And of course, I say classical study design because the protocol defined the target blood pressure for brachial management. And that was achieved, as you see here, in the sub-study of over 2,100 patients. The brachial systolic pressure was not statistically different and about 133 mm of mercury. The study was stopped early because of differential cardiovascular outcomes. So someone would say, okay, we have a study of thousands of patients with one set of inclusion criteria, with one treatment protocol for managing blood pressure that was stopped earlier because of differential cardiovascular outcomes. How could that be? Is there a benefit perhaps beyond blood pressure? Well, in fact, the CAFE study showed that there was actually a differential central effect between the two drug regimens. The amlodipine arm actually had a lower central systolic pressure, in fact, by a matter of 4 mm of mercury, 121 versus 125 in the atenolol arm. So this is an example of differential blood pressure effect because of the vasoactivity of the drug reducing arterial tone. And here the authors concluded that BP lowering drugs can have substantially different effects on central aortic pressures and hemodynamics, despite a similar impact on brachial blood pressure. The next study I'll cover is the Strong Heart study, an NIH-funded study in American Indians. And it's a very broad reaching study. This is just one component of it. But in this component, they looked in 4,500 participants. They looked at hazard ratios for cardiovascular outcomes by blood pressure, by pulse pressure quartile. And here we see the 4 quartiles of brachial and central pressure. The brachial quartile is defined across the top row of the numbers here, and the central quartile is defined below. But the most important thing to notice is that only one quartile, when compared to the first, showed a statistically significant difference in hazard ratio. That ratio was 1.69 for that quartile, which had a lower limit of 50 mm of central pulse pressure. So here you have an example of the central pressure being more specific, and that's a function of the variability of central pressures within those brachial pressures that we talked about earlier. So here the authors concluded that non-invasively determined central aortic pressure better predicts incident cardiovascular disease than does brachial pressure. I would say that the BP guide study is sort of next in the logic chain here. And that is to say, okay, if we know about differential effects and we know about the specificity of central pressures being perhaps more predictive, if you will, than brachial pressures, then can employing a device like this and these kind of measures actually change the way we manage patients, and can we get them to goal faster? And here I'll stop and define goal very quickly, and that goal is brachial blood pressure management. we know that the guidelines are written on brachial pressures, and we don't propose that we change those. But what we do propose is that, as was evidence in this study, that adding central pressure waveform analysis can inform blood pressure management and improve that care. So this was a study that was a 1-to-1 randomization in a little under 300 patients, comparing standard of care with standard of care plus central waveform analysis. And here what they found was that those who had the additional benefit of central waveform analysis got to blood pressure goal, to brachial blood pressure goal faster and on a lower daily defined dose of drugs. So this was a nice establishment of the fact that guidance of hypertension management with central BP results in a significantly different therapeutic pathway than conventional BP, with less use of medication to achieve BP control. One other finding in this study that I'll briefly touch on is that in the group managed with central pressures, they actually determined that they were comfortable actually terminating antihypertensive therapy in about 16% versus about 2% in the brachial only arm. So an interesting detail there that I would recommend taking a look at this paper. You know, one thing I forgot to mention when we started, and I apologize for that. If you have questions, please use the chat function, and those questions will be passed through, and Dr. Houston will be able to comment on those when we conclude. And I'm very sorry for not having mentioned that earlier. The last study that I would like to cover was published earlier this year and looked at the relationships between measures of blood pressure, both brachial and central, and silent brain infarcts and white matter hyperintensities. This was in an elderly population of about it was 993 subjects, average age of 71.7 years. And what they found was that brachial pulse pressure was correlated with silent brain infarctions, as was central pulse pressure. But central systolic pressure and pulse pressure were correlated with white matter hyperintensity volume, while no measure of brachial pressure showed any correlation with that measure. As I'm sure many of you know, white matter hyperintensities have been linked to dementia and Alzheimer's disease. So this was an important finding. And in an accompanying editorial, Dr. King mentioned that determining that only central blood pressure measurements were linked with increased white matter hyperintensity burden may have important clinical implications for management of blood pressures among the elderly to promote healthy brain aging. And finally, for this portion of these slides, a symposium was held by the North American Artery Society, which asked the fundamental question: given the evidence that's available and given our clinical experience, what does that tell us about how this technology should be used in blood pressure management? The first of those use cases was actually deciding whether to initiate intensify or change therapy in younger asymptomatic patients. And I say whether with emphasis because in some cases, as I showed earlier, if you have a relatively low central pressure for a given brachial pressure, a clinician may determine that they're going to wait, rely more on lifestyle or other non-pharmaceutical interventions for people that are younger. And this is one of the ways that you can inform that decision. Second use case was deciding on the class of drug to add when it's decided that another medication is needed based on brachial BP for traditional hypertension management. So a patient comes in, they've been seen for 6 months, not happy with the results. Let's look at how much wave reflection they have, and let's look at their heart rate and other things, and let's decide how we want to bias the selection of the next drug based on more than just the 2 numbers from brachial pressure. And third, this technology allows for comparison between visits to say, okay, last time we added a calcium channel blocker, let's see if we were able to reduce wave reflection. If we were low enough earlier on wave reflection and we didn't have an effect, maybe we don't need that extra dosage or that extra drug, and maybe we can eliminate a few side effects with that. So these were the recommendations for that group. The SpimoCor Excel is the device that ATCOR offers, and it is pictured here. This actually leverages the use of a brachial cuff, but in a very dramatic fashion. In that, this is a device that measures the brachial pressure and then actually measures a brachial waveform and the computer that the device is attached to processes that information and generates not just the brachial pressure, but the central pressures and central waveform, as we'll discuss. One thing I'd also like to point out is this device meets the current ACC and AHA guidelines of an unattended oscillometric device that can average multiple brachial pressures. So this can be programmed up to 5 brachial pressures, keeping and discarding the first before it proceeds to measuring the waveform to capture the central, to derive the central pressure. The key thing I'd like to say about the spinal cord technology, given that it uses a cuff, is that the fundamental skill that you need to use it is knowledge of proper blood pressure measurement, which we all know is proper cuff sizing, proper cuff orientation, patient rest, and patient posture. If you have all those things, that's what you need to know to be able to use this device effectively. What I'm going to do now, very briefly, is I'm going to walk you through how this device works. And here you see our setup screen, which has the traditional sort of patient demographics that you would enter for a new patient. But in this time, I'll point out that when you have a population of patients that have been registered, you can sort on any of these variables: last, first name, date of birth, etc. But let's say that we're going to do an assessment on, let's pick someone. Here's a 40-year-old male, he's already in the system. So we've got him seated, we've got the cuff on and properly sized, and he's rested. And then we select start. Now I'm going to run this in simulation mode. So I want to caution you that when you see this brachial pressure measurement, it'll take about 3 seconds. That's not real. This is simply a simulation, so that happens very, very rapidly. Everything else that you'll see is relatively real time though. And you can see that this device only adds a matter of seconds to a traditional brachial pressure measurement. So I press the start button and we capture the brachial pressure. As I mentioned, that's dramatically accelerated, but we've captured the brachial pressure, and now we delay for a few seconds before we reinflate the cuff to capture the brachial waveform, which is what you see on the screen here. This has been set for a 10-second capture window, so it's almost complete, and there it is. Once that's complete, the computer processes the information and generates this output. So without belaboring this screen, because I have a few simple examples I'd like to walk you through, I'll just point out that the outputs are, of course, the brachial pressure, and then we have the central systolic pressure and central diastolic pressure. And then, of course, we have the central pulse pressure. We have the augmentation pressure, which I touched on before. And we have the augmentation index, which again is the ratio of the augmentation pressure divided by the central pulse pressure, in this case, about 15%. These are plotted against age and gender specific ranges or 90% confidence intervals for a healthy person of that age and gender. So now going back and just walking through a few examples here to show you how you'll see variability and how it can affect drug selection or other interventions. I want to highlight the fact that I don't want to propose that these are case studies, because I'm not giving you all the other medical history and everything that you would normally do to properly assess a case. Rather, I'd just like to focus on the types of variability that you'll see in the output from the device and how that can affect adding information to brachial pressures to personalize the management of these patients. So the first example is a 57-year-old male who has a brachial pressure of 146/92, certainly hypertensive, regardless of which guidelines you're following. This patient also has a heart rate of 89 beats per minute, but you'll also notice they have relatively low augmentation pressure. So their wave reflection is sort of on the very healthy side of a 57-year-old man. There is a little bit of wave reflection there though, so that might be part of the target in prescribing drugs, but it may be that in this case, a heavier emphasis is placed on beta blockers. And so, it may or may not be a combination of basic beta blockers with vasoactive drugs such as calcium channel blockers or ACEs. But knowing that information about the degree of wave reflection and the heart rate is very helpful. Second example is a 54-year-old male with a brachial pressure of 169/81. Of course, this person has significant hypertension. They also have a relatively normal heart rate of 78 beats per minute. But notice, both in the waveform and in the results that you have a very low degree of wave reflection. This may be someone who's been followed for 6 months, has been pretty aggressively treated with vasoactive drugs, but they still haven't got their blood pressure down to the target that they would like, obviously. And it may be then a case like this that a vasoactive drug just simply won't seem to be the next step because there just isn't much wave reflection to fight. But in this case, maybe a volume reducing agent like a diuretic or an increase in diuretics. And the final example is a 33-year-old female with a brachial pressure of 151/94. This, again, classically hypertensive, heart rate of 88 beats per minute, and significant wave reflection. Here we have an augmentation pressure of 13 millimeters and a high central systolic pressure and high central pulse pressure. So this is a patient that you would certainly want to treat with a vasoactive drug and perhaps a beta blocker to treat that because of that heart rate. But as a woman of childbearing age, you might be more tend more to treat with calcium channel blockers than ACEs or ARBs. But again, the selections are there and the information is there to individualize or personalize that care. So finally, if we think about the utility of the information I presented to you today, we have an opportunity to improve risk assessment and stratification. Keep in mind that differential blood pressure amplification I talked about, where you have similar brachial pressures but dramatically different central pressures. They allow you to understand that the brachial pressure is not giving the whole story on risk, and they can certainly better inform that information. The next is blood pressure phenotyping and individualization of treatment plans. Understanding how much wave reflection versus volume is going to bias your therapies more towards the vasoactive drug end of the spectrum, if you want to call it a spectrum, versus the diuretics. And finally, retrospectively, being able to understand the effects of intervention by seeing what the true effects those were on the central pressures and the waveform that the heart and the brain and the kidneys are directly exposed. So that wraps up my portion of the presentation. I think most of you know that Dr. Houston's most recent textbook is Personalized and Precision Integrative Cardiovascular Medicine, and it therefore dovetails perfectly with the topic of today's webinar, and really a good segue into the opening of our Q&A session. I'm going to Dr. Houston, if I may, I'm just going to open with a quick open-ended request that you might speak to us about the broad topic of arterial aging and the arterial stiffening that occurs naturally as we age.
Arterial aging is a great coexisting factor with aging in general. As you get older, particularly in this country, there are a lot of factors that cause the arterial system to lose its arterial elasticity, increased stiffness, and thus all the pressure waveforms you've talked about, augmentation index, tend to go up as you get older. Some of that's related to underlying risk factors like hypertension, dyslipidemia, diabetes, obesity, smoking, homocystinemia. And many of those, you can try to treat, but the aging process in general is going to affect the arteries no matter what you do, probably. And the biological aging process is something that's very difficult to control. But having said that, we do have both nutritional, supplement, and drugs that will actually slow down vascular aging now.
That's very good. Thank you for that. Another question is, do you, in managing augmentation index, do you make a distinction between the classes of vasoactive drugs, or do you relate those more to comorbidities as you look at how you might treat wave reflection in these patients?
I really like to use different terminology rather than vasoactive because it doesn't really get to the root of the problem. So I think each class has to be clearly defined. And so let me give you the broad view of the CAFE trial, which you mentioned earlier, and what we know how the different drug classes affect arterial elasticity, for example, arterial compliance, vascular aging, central blood pressure versus brachial blood pressure. And every class is different. So the CAFE trial, as you pointed out, showed very clearly that the beta blocker atenolol and hydrochlorothiazide did not do well compared to an ACE inhibitor or an ARB with amlodipine. Amlodipine with an ACE or an ARB always outperforms a beta blocker or a thiazide diuretic in everything you look at, whether it's stroke, heart attack, heart failure, kidney disease, or parameters of pulse wave analysis, always. And there's a lot of reasons for that. And the CAFE trial clearly showed that even though the brachial pressure looked the same, thiazide diuretics, virtually all the beta blockers except for two classes, do not lower central blood pressure. And therefore you had the difference in target organ damage. Now, the old beta blockers all increase arterial stiffness. They increase vasoconstriction. They are not good drugs for hypertension, and they're no longer used. They're off every single hypertension guideline in the country, ACC, AHA, and American Society of Hypertension. Only two beta blockers remain useful in hypertension. That's Vistalic and Carvedilol, because they're vasodilating, not vasoconstricting. And the diuretics are no longer, thiazides are no longer recommended. Hydrochlorothiazide is gone. You should not be using it anymore. If you're using it, you need to get people off of that and off the older beta blockers. The only diuretic that we're recommending now for hypertension is indapamide. A close second, but not very close, is chlorthalidone. And there's a lot of problems with chlorthalidone, so I don't use it unless I have to. So indapamide is best with the diuretic group. Now, of the other classes, dihydropyridine calcium channel blockers, amlodipine, nifedipine, clearly the best in that class. Any of the ACEs and any of the ARBs work to lower central pressure, improve arterial elasticity, and make the compliance better. So in essence, it's not that hard anymore to know what to do based on arterial function and structure, elasticity, and aging. Your comorbidities really determine which of the classes you might use. But in general, amlodipine with an ACE, amlodipine with an ARB, with a diuretic like indapamide, and if you need to, you go to Vistalic, Carvedilol, and you've got those backed up with drugs like amiloride and spironolactone for specific indications.
Thank you for that. One question from the audience: do you have central systolic blood pressure goals or targets that you would recommend?
Yes. As you get older, perfusion issues become a problem. If you drop the systolic pressure too low, because the arteries don't constrict and dilate as quickly or as far as they should. So a lot of older people, when they get to the point their arteries are very stiff, you've got to maintain, unfortunately, a higher systolic pressure to keep perfusion to the brain and the heart and the kidneys normal. That's not to say that's what you want, but it's just that's a fact. But if you look at the broad spectrum of hypertension in a population that's not in this country, that's in a Paleolithic sort of era where they don't get fat, they exercise and they eat good, they don't get systolic hypertension as they get older. So what's really normal? Well, in a population, 110 to 120 top number systolic and 70 to 80 diastolic. That's where you'd like to be to keep your optimal cardiovascular risk the lowest.
Well, I was going to ask you a personal, something I've been curious about ever since the sprint findings, but you've just touched on it, and that was, do you have any concern about how aggressive you might be in managing a brachial pressure in an elderly person if you don't have visibility to their central pressure? Because I think if you think about people with a lot of amplification and therefore very low central pressure, they may become hypotensive in a way that can't be measured from a brachial cuff.
That's exactly right. And that's one clear indication to be able to have a machine that measures central arterial pressure, because in that case, you can under and over treat those patients. You just don't have the correct data. And we see this all the time. People that come in with a systolic brachial pressure of 180, but you check their central pressure, it's only 160. So you can imagine what would happen if you try to get those people down to a normal number and you think it's really 160, but it's not. So you've got to look at both parameters to determine what's the risk and what's the treatment and what's the goal.
Yeah. One point I'd like to raise to the audience is that we are receiving a number of questions, and if we don't get to them, we'll do all that we can to to get a response, whether it's directly from Dr. Houston or this question. I'll cover it very briefly. And the question was, is this procedure reimbursed? In fact, there is a CPT code for central blood pressure waveform analysis. It's 93050. The coverage, as with the case with virtually all most CPT codes, is that it varies from region to region. So if you have a specific question about your local area, give us a call at ATCOR and we'll take that for you. The next question that I have is, you've kind of just covered it, but I'll ask it because the audience specifically asked it. Do you have any preference between the current guidelines? We have the post-sprint guidelines, and we have the JNC 8 guidelines, and we have distinctions between races and diabetic status and things like that. And I'm just wondering if you can make sense of it.
Okay, well, the most recent guidelines are from the American Society of Hypertension and the ACC and AHA, and they're all one central guideline. And all the guidelines are pretty clear. Average blood pressure should be 120/80. And you get to that, now that's obviously brachial pressures, but that would apply to central pressures as well. So you do those with office measurements, you do it with home measurements, and if you're really up to date and do the 2020 correct type of measurements, you do a 24-hour ambulatory blood pressure monitor, not to get the average only, but also to get the dipping patterns of variability and other things, which a lot of the audience knows about because we've been talking about that for years. Then you add to that, do they have any risk factors? Do they have target organ damage already? Have they had a stroke? Have they had a heart attack? Have they heart failure, kidney failure? Do they have diabetes? And then you decide what medications are most appropriate for that comorbidity. But the level of blood pressure in general is going to be pretty close to the same, unless you're really an older patient, in which case you got to be more careful, particularly with a span of the systolic being too high. But then if you give medication, you drop the diastolic too low and they have syncope.
Yeah, okay, all right. I'm looking for other questions from the audience. I'm not sure that I'm seeing any more right now. They're being communicated to me, so I hope we haven't had a breakdown there. Other sort of, are there things about this broader topic, despite my hopefully appropriate but hopefully not too long presentation? Are there things that you thought I might not have covered, or even that you would correct or otherwise enhance it to the group?
We've been doing the pulse wave analysis now for a long time, so we've got a lot of clinical data. I know it works. I know it doesn't work. So the important information I think the audience needs to know is you really can't practice good clinical medicine now without having central blood pressure. You just have to have it. You can't predict risk. You can't predict goals. You can't predict treatment. You don't know how stiff the arteries are. I mean, there's no way to get around it. So central blood pressure matched with brachial pressure matched with a 24-hour ambulatory blood pressure monitor is the standard of therapy now, or standard of diagnosis, I should say. Once you have that information, what do you do with it? You gave a lot of clinical examples, but let's say you have a patient who clearly has hypertension by both brachial and central pressure. They have stiff arteries as measured by the augmentation index or whatever criteria you'd like to use to determine that. How do you get the arteries to be not stiff? That's the big question. I mean, people can say, well, I got the data now, tell me what to do with it. Well, first thing, you identify the reason they got that way and you treat it, whether it's one of the risk factors we talked about, diabetes, hypertension, dyslipidemia, smoking, whatever, homocystinemia, or just the fact they're old. But is there a point in which the stiffness becomes not fixable and it's just stuck? So you have to look at, I guess, sort of the pathways of going from normal to a little stiff, moderate, severe, and then end stage. And before you get to end stage, there are things you can do that will actually increase arterial compliance and reduce the stiffness. So here's what you start with. Nutrition. Number one, get the sodium low intake down to 1,500 milligrams a day. Potassium intake high at 5,000 milligrams per day. Magnesium intake high at 1,000 milligrams per day. You do that with nutrition. If you have to add supplements, you can do so. Secondly, you get them to lose to their ideal body weight and body fat and start to exercise both aerobically and also using resistance training done safely after you've measured a cardiopulmonary stress test and their blood pressures and see what happens. The next step is using specific supplements that actually increase arterial elasticity. And the best is beetroot extract. And there's a lot of companies that make beetroot extract. But if you look at the clinical evidence, and we've done 2 studies now in the Hypertension Institute using Neo40, and Neo40 works. It will usually within 4 months improve arterial elasticity in virtually every patient unless they're at the severe end organ stage. And also there's another supplement we're using called MitoQ, or a very specialized form of CoQ10. It gets into arterial wall and the cardiac muscle at very high concentrations, 1,000 times more than regular CoQ10. That's not to say you shouldn't use both, but if you use Neo40 and MitoQ together, the results are dramatic. And then the third step is to get the blood pressure down with an antihypertensive that works to increase arterial elasticity and reduce augmentation index. That's amlodipine or nifedipine as a calcium blocker, any ACE inhibitor, and any ARB. 2 beta blockers, Bistolic and carvedilol. You avoid old beta blockers. You avoid thiazide diuretics. And if you need a diuretic, use indapamide or aldactone or amiloride. That's it.
Very helpful. Yeah, and I think that, to be frank, you stole what I thought might be a wrap-up question, which is sort of the broader, philosophy. But I appreciate that very much. But however, I do have one more question from the audience here, and I'm going to read it to you. ACEs and ARBs increase ACE2 receptors. Is that an issue considering SARS-CoV-2 binds to the ACE2 receptor?
That's a very good question. And it was one that was out there at the very beginning of the COVID-19 epidemic. And unfortunately, one doctor had a postulate, which he published in Lancet, that was totally incorrect. And he's now eaten his entire Lancet magazine for having said that. He postulated that ACEs and ARBs would actually increase the risk of COVID morbidity and mortality because it increased the ACE2 enzyme. Well, that was wrong. Now we've got clinical trials in humans that show very clearly that ACEs and ARBs decrease the morbidity and mortality of COVID infection. Why is that? Well, it makes sense if you think about it. If you understand vascular biology, this was not hard to figure out at the beginning. And we actually wrote an editorial saying the Lancet was totally incorrect and this is what it should have been. ACE2 goes up with both ARBs and ACEs. The ACE2 enzyme is protective against inflammation, oxidative stress, and immune vascular dysfunction. So if you have a lot of ACE2, it actually, through a different mechanism, increases a compound called angiotensin 1,7 that has its own receptor. It's called the MOS receptor. The MOS receptor is just like the angiotensin 2 receptor. It increases nitric oxide, decreases inflammation, decreases oxidative stress, and decreases cardiovascular morbidity and mortality. And guess what? A lot of ACE2 is also in the lung. So the same issues apply in the lung and in the kidney and in the brain. It's all the same enzyme. So if you start with a high ACE2 and you zap it with the coronavirus, it gives you a lot of leeway because you got more ACE2 around that the virus is not going to take out. And if you're on the drugs, it keeps that mechanism ongoing. In addition to the studies with ACEs and ARBs, we also found out if you give nitric oxide through an agent that increases nitrates and nitrites in your system, like Neo40, you get an extra benefit. So the increase in NO through the MOS receptor, angiotensin 1,2 receptor, and the increase in NO by giving a supplement like a Neo40 gives you extra benefit. There are actually some studies using inhaled nitric oxide into the lung that show benefit, but you can also take it as a supplement orally. So let's make it really clear. Do not change anybody on an ACE or an ARB off their blood pressure meds because you think it's going to harm them. Keep them on it because they actually decrease morbidity and mortality with COVID.
And I think that's a great segue to what I think will probably be the last question of this webinar, and I thank you again. And that is, as we envision exiting this pandemic, whenever that may be, do you think that the things that we've learned about things like high incidence of hypertension in the patients who had difficult course will change the attention and the focus on things like blood pressure management as we try to improve health as we come out of this pandemic?
It's very clear that high-risk populations had a higher morbidity and mortality from COVID, no question about it. Hypertension was in that list, and I'll come back to that in a minute. Also, diabetes, obesity, other cardiovascular problems. So get healthy, and you're not as likely to die from COVID. But here's another misconception. It said, all the literature said, if you're hypertensive, you're at high risk for COVID problems. Now we know that it's not the hypertension that's the problem. It's the comorbidities with the hypertension. It's the vascular problems with the hypertension, but it's also what did they get treated with? If you were on a beta blocker or a thiazide diuretic, in all probability, you got more inflammation because those drugs actually don't improve through the ACE2 enzyme like ACEs and ARBs. CCBs do it a little bit and they're more neutral, but if you look at the data totality now, it's pretty clear what's going on. Now, the good news is we're going to have a vaccine probably in September through AstraZeneca. 2 billion vaccines for COVID in September, which will vaccinate 400 million in the United States, and most of the world and other companies will be out with additional vaccines. So it's going to take a long time to get all the people vaccinated, but I think, in a very short period of time, we're going to have the COVID-19 virus hopefully under control, and that one will not stick its ugly head up again if everybody can get vaccinated and they maintain good immunity with the vaccines, which look to be very promising. However, there will be other viruses that will come out that we'll have to deal with, but at least we'll get this one hopefully in the past.
Well, that's a hopeful note. So that might be a very good place to end this webinar. I really appreciate that.
My pleasure. Thank you.
Thank you again for your time today. And thank all of you for attending our webinar.
Thank you all for coming.
Okay. Bye-bye.
Bye.